I am Dr. Nagaraj Desai. I propose to do certain presentation today. It is recommendations on lipid management, and the guideline is based on certain foundations like you have the dyslipidemia causing the atherosclerotic cardiovascular disease. Importantly, by intervening these lipid abnormalities, particularly LDL cholesterol levels, result in reduction of cardiovascular events. And also, there is an absolute reduction of these cardiovascular events by reducing these LDL cholesterols at a expected therapeutic levels. And indeed, by categorizing these subjects into very high risk and high risk, prioritizing their treatment, the guidelines have recommended. In fact, this particular guideline is based on wherein we recognize that the dyslipidemia causes atherosclerotic cardiovascular events, and treating these dyslipidemia can result in significant number of individuals the atherosclerotic cardiovascular events. Further, the guidelines do recommend by looking at the baseline LDL cholesterol levels and also the risk estimation of these atherosclerotic cardiovascular events. The guideline further would like to prioritize on recognizing the very high risk individuals and high risk individuals. When we take a look at these guidelines, we should try and understand that what is the baseline LDL cholesterol. When we take a look at the patient's intensity of the lipid lowering therapy, the degree of benefit that is achieved by just statin alone with the moderate intensity statin, as we call it, average reduction is 30%. In case we employ the high intensity statin therapy, the reduction is something like a 50%. And beyond that, when we add estimib, it will be something like it goes up to about 60. And in case we add on the PCSK9 without estimib, it can be up to about 75%. In case we add on all these three drugs like the PCSK9, statins, and also estimib, the reduction is something like 85%. Further, when you take a look at the baseline LDL cholesterol, if we reduce this LDL cholesterols significantly, then there is relative risk reduction significantly. And most importantly, if the risk is higher, our baseline risk is higher, the absolute risk reduction is also higher, indicating that when we want to evaluate a person, we should take a look at the LDL cholesterol levels at the baseline and also the basal risk of this particular individual who is likely to develop the cardiovascular event. There are three stages in this risk stratification process. Here, we take a look at the patient as a whole, and also we employ a scoring system, score of 10-year risk estimate using the fatal events. Assessment of the risk modifier is also an important aspect of this particular risk estimation, wherein one recognizes the presence of risk factors, including, for example, the lipoprotein little a, C-reactive protein, family history of coronary artery disease, and presence of atherosclerotic plaque indeed may be in carotid arteries, or even calcium scoring, which can also inform us, saying that whether that particular patient is higher risk or not. By doing this, we are going to recognize a person whether he is going to have a higher risk or a lower risk. Indeed, the ESC has categorized this as a class 1 recommendation at the level of C of recommendation. Now, clinical assessment is going to result in patients who are in the very high risk, or a high risk, or a moderate risk, or a low risk. All this information, you will be able to categorize the patient's risk score as a very high risk score, moderate risk, or a low risk score. This score system can be used without any clinical risk, clinical ASCVD being present. That should be understood by us. And in fact, when we have to place a category of a patient into a higher risk, then this combination of lipid levels and other risk factors could be useful. The charts have to be interpreted in the light of clinicians' knowledge and experience and patients' pre-test likelihood of cardiovascular disease. In other words, this is likely to be underestimated in people where the mortality rate is increasing, like for example in India, and this has to be dealt by calibration. But of course, when we come to the Indian recommendations, we will discuss a little more about it. The risk estimates are likely to be lower in women than in men. If you examine the relative risk, may be undoubtedly high in younger persons, but if the absolute risk levels are low, then these may not be very important. But the relative risk chart estimated age may be helpful in identifying those and counseling such patients, in other words. So coming to the kind of gist of this particular part of the talk, wherein you can see here, total CV risk assessment is necessary by using the scoring chart, and the basal LDL levels are important. And when we employ the risk modifiers and also the charts that have been available here, by recognizing these risk modifiers like the subclinical atherosclerosis that have been listed here, you can reclassify these patients, whether these patients require to be treated with the medicines or not. So key message here is that the people, when they are healthy apparently, there can be some kind of additional risk factors which can be operated, and these will have to be estimated by the cardiovascular risk estimation and accordingly managed. Most importantly, there are some people who are already having the familial history of hypercholesterolemia, kidney disease or carotid disease, or the presence of diabetes, or you already have a calcium score or extreme levels of the LPA elevation. These will have to be considered as a very high risk individuals and appropriately treated. Nevertheless, the categorization of the individuals at the very high risk, the high risk, moderate risk and low risk is very useful, and compare them with the 216 recommendation to 2016 recommendation to 2019 recommendation by the ESC. You can see clearly the guidelines have gone further to bring down the LDL cholesterols in the very high risk, something like when you employ more than 50% reduction of the LDL cholesterol strategy, then you can have something like a goal of something like 55 milligram per deciliter, and accordingly the risk for the high risk individuals will have a 70 milligram, moderate risk people will have 100 milligram, the low risk people will have 115 milligram, indicating that when we have the 2019 recommendation for these category of patients, it will be useful for us to know that the science has progressed further simply because with the addition of the molecules like the PCSK9 inhibitor in our clinical armamentarium. Now, these evidences, as I was telling you in the previous minute, have evolved by examining several lines of evidence like the meta-analysis of the cholesterol trialists, IMPROVE-IT trial using the estimate, and the Fourier trials like using the evolocumab PCSK9 inhibitor, or alirocumab PCSK9 inhibitor like the Odyssey trial, for example. All these trials were examined for bring out these recommendations. Now, by looking at the values that we obtain out of statin therapy, you can clearly see the lower the value, the less number of events you can see in the population, as was seen here in this particular chart. You can see here when we reduce the LDL cholesterol levels to the minimum of something like 1 millimole, you can see the number of events dropping down so significantly, indicating that more intense the cholesterol reducing agents are used, more benefits we are going to get out of the cholesterol, rather the vascular events in our population. Of course, it goes without saying that we have to manage the patient's lifestyle issues, including the smoking, the diet, the physical activity, the body weight, the blood pressure, and of course the patients who are on these therapies. For example, the LDL cholesterols, the goals have been set in here, wherein we'll discuss it a little later. Of course, the diabetes has to be managed with the HbA1c of less than 7. Going on further, actually most of the benefits, major benefits, were obtained out of the secondary prevention program. It is useful for us to discuss the recommendations of ESC of the secondary prevention program. We can see that in secondary prevention patient at very high risk, the LDL reduction of at least 50% from the baseline. That means we have to have the baseline examination of the LDL cholesterol, and if it can be brought down to something like less than 55 milligram per deciliter, that is a recommendation. It is a class 1A recommendation. In other words, all of us will have to strive for this level of LDL cholesterol reduction by employing the statin therapy, so that that comes down by something like 50% of the baseline. In the primary prevention, for instance, where the patients have hypercholesterolemia of the familial variety, wherein again you can try for 50%. And in primary prevention, again, if they have familial history with the LDL cholesterol reduction of at least 50% from the baseline, that should be considered in all those patients who have a familial history of hypercholesterolemia, indicating that the secondary prevention program, there is no doubt about we bringing down the LDL cholesterol to something like 55 milligrams, employing something like 50% reduction at the target. Indeed, for patients who have second vascular event after a myocardial infarction, for instance, or with some other secondary vascular event occurring in some other territory, for instance, peripheral artery disease or cerebrovascular tree, while taking maximally tolerated therapy, then the further reduction is recommended, but although it is a class 2B, indicating that the recommendation is a little weaker in that. Now, if the patients are at a high risk, then LDL cholesterol reduction of at least 50% from the baseline, and of course the 70 milligram deciliter of the LDL cholesterols are recommended. Again, it's a class 1A indication, and the recommendation by the cholesterol recommending European Society of Cardiology. Of course, if the patient is in a moderate risk, the goal is less than 100 milligram, and if the patients are at a lower risk, here you can see that 116 milligram is being considered as a class 2B recommendation. This treatment algorithm is very useful for us to understand here. This total CV risk assessment after it is done. You can see the baseline cholesterol levels are obtained, and if the patient is already at a risk for which you require to employing the risk modifiers as was discussed earlier, wherein you will use the subclinical atherosclerotic measurements like the calcium score or carotid intima media thickness, or even peripheral femoral artery plaque, for instance. You can reclassify them into upper category. And of course, if the patients are eligible for drug therapy, you can continue the drug therapy and define the treatment goal here. Is a patient for high potency statin or highest recommended, or tolerable dose to reach that goal. And of course, once the LDL cholesterol is reached, you can see clearly that you will follow up annually, and subsequently you will follow up the patient regularly. Indeed, if the patient's goal is not reached, you may have to add an estimate here, and then you can see whether the LDL cholesterol goal is reached or not. If it is not reached, then only you will consider adding the PCSK9 inhibitor, wherein the secondary prevention program comes in, and for a selective patient of a primary prevention where they have a familial history of hypercholesterolemia there in a particular patient. Now, of course, even in those patients only, you will consider PCSK9. In other words, friends, the European Society of Cardiology, in general, recommends the statin therapy in patients who are non-responsive to statin therapy, consider estimib therapy, and those people who are not responding to both of these category of the drugs on adding in an individual patient may consider the PCSK9 inhibitor therapy. It is worthwhile to compare the European recommendations with the ACC-AHA recommendations, which were just released last year, simply because both Western societies do recommend almost in a similar manner. They assess the risks, estimates. They also give respect to the LDL cholesterol levels and the intensity of the reduction of the LDL cholesterol levels. Almost all the same. Somehow some kind of variations are there. Both the guidelines do recommend the statin therapy to maximize, and the high-risk patients are covered very well. And of course, the LDL cholesterol as the primary target is also recommended by both. And both these guidelines do recommend about the 50% or more lowering of the LDL cholesterol, and also for specific levels of the targets for special populations. Now, of course, the very high-risk patients are those people who already have the cardiovascular event that's called the secondary prevention as suggested by the ACC-AHA. And of course, they do consider that two major cardiovascular events are defined by the presence of the cardiovascular coronary events or the peripheral artery disease or even the stroke. All these are considered at the very high risk category. Indeed, the ESC, for ESC, anyone with documented cardiovascular disease, either clinically or by imaging, is considered as a very high risk. And of course, even in the absence of the atherosclerotic cardiovascular CVD, the familial cholesterolemia, for example, it considers as the high risk event, in fact. Now, the threshold for the ACC-AHA as for the LDL cholesterol concerned is 70 milligram deciliter before considering the addition of a non-statin therapy in high-risk patients. And the ACC guideline recommends that estimib should be considered first, since it is a generic medication and can be given orally. The ESC guideline recommends that all patients achieve the more than 50% reduction in baseline values and an absolute value of less than 55 milligram per deciliter. The functional difference introduced by the ESC is largely therapeutic intensification between 55 and 70 milligram deciliters, wherein they want to push the envelope further by reducing from 70 to 55 in a given patient. Now, coming to India, you can see that the Indian scenario is emerging as almost like an epidemic proportion wherein the younger individuals are affected, and studies have shown that the people from South Asian origin, which are categorized as a high-risk category, wherein they have a multiple vessel involvement, diffuse coronary artery disease, they do get the coronary events at a younger age. In other words, they are difficult to manage sometimes, indicating that these are high-risk individuals, and if the lipid plays a pivotal role in the causation of the atherosclerotic disease. This particular publication, which came from India, and just about 404 physicians participated in this particular study, and there was tremendous variation in the practice of lipidology or recommendation of the statins for this particular set of individuals. And many people who deserved statin, the physicians deferred giving the lipid modifying agents, indicating that we have a long way to go, because this happens to be just a 2-year-old publication which came in the journals. If you take a look at this particular slide, where is ICMR INDIAB study, wherein the 2,000 patients were kind of examined, you can see clearly that the number 1 was the low levels of the HDL cholesterol, and number 2 was the hypertriglyceridemia, and number 3 was the LDL cholesterol, indicating that our lipid profile is slightly different. Still, the universal screening of all Indians are necessary simply because the prevalence of these risk factors seem to be occurring at a lower level. And in fact, Lipid Association of India do recommend screening for all individuals starting from the age 20 itself or before. And that should be the way to go, so that many of these lifestyle diseases are recognized and the lifestyle risk factors are recognized and prevented. We have to recognize that there is what is called a lifetime or cardiovascular risk instead of 10-year risk. 10-year risk, when we identify at the age of 25 or 30, then we are covering the distance of something like a 45 to 50. We want to go beyond that. That means we have to make sure that we have this lifetime risk calculators for us, and this particular calculations can be obtained from the Joint British Society's 3 risk calculator is found to be most comprehensive in Indian population. This particular approach to the Indian lipid abnormalities is very useful, and in my opinion, it is very comfortable for all of us to use. You can see clearly that we do recognize the patients having a very high risk and a high risk, and of course the categorization remains the same. This particular slide will tell us about the very high risk, moderate and low risk here. At the top of the slide, it is almost like the other ESC guidelines, wherein the LDL cholesterol is something less than 50 milligram, and non-HDL cholesterol, because our high triglyceride and HDL levels being low, we also consider after receiving the LDL cholesterol to the goal, we talk of the HDL cholesterol, non-HDL cholesterol after measuring the HDL cholesterol also. And of course, the drug therapy should be considered in those people who have that particular level. For example, LDL cholesterol levels are more than 50, then it should be treated for that. And of course, if it is more than 80 for the non-HDL cholesterol, it's again treated for all of these category of patients for high risk category, very high risk category. High risk category, again, the numbers are there in front of you. Coming to the bottom of this slide, you can see here the low risk category, wherein the number of people who will be treated for the drugs are lesser, obviously, because the LDL cholesterol is more than 130 and LDL or other non-HDL cholesterols of more than 160 milligram, indicating that along with my other colleagues, Dr. Iyengar, he published this article in JAPI 2019, and appropriate use of PCSK9 inhibitors in India, simply because, of course, these drugs are expensive and are often not used by us simply because of the cost. In other words, when we talk of PCSK9 inhibitors, they will have to be kind of limited to certain kinds of individuals who possibly have a highest risk. So to summarize, we have a routine screening for all of our Indians at the age of 20, why not 20, or as they are getting admitted to the hospital. And of course, once we have a lipid abnormality, it is our duty to make sure that the secondary varieties of hyperlipidemia is ruled out. For instance, the alcoholism, hypothyroidism, and what else you have. We would like to use the risk assessment by using the scores and make sure that we use the correct score for our population, and Joint British Society's 3 score is very useful for us simply because this particular score included the South Asians also. And of course, we categorize these people into various categories like the very high risk, moderate risk, and low risk categories. Of course, LDL cholesterol of less than 50 milligram is safe. Non-HDL cholesterol levels have to be targeted for, especially in our Indian populations. Of course, all patients of dyslipidemias should be treated by statin therapies, and those who require some additional modifications of the lipids, estimib is a second choice that require to be used. And importantly, the PCSK9 inhibitors which are available now should be reserved for few patients wherein they are going to benefit out of these PCSK9 inhibitors, where the LDL cholesterol reduction is supposed to be in the range of something like 70 to 80%, I guess. Of course, the lifestyle modifications will have to be addressed in all the patients, all the people who have abnormal lipids, and the lifestyle modifications are necessary for all of us indeed. Thank you so much.